Okay, thank you. First of all, good evening, doctors, and welcome to this webinar. And myself, Mainuddin from ESI Pharmaceutical, greeting from the ESI also. So, first of all, I like to welcome Dr. Niti Madam. She is a senior director for the medical and hematology Fortis Hospital. So, welcome, ma'am, for this program. And she is a program director. So, she will be continuing the further proceeding for the program. And I like to hand over the madam for the session to take over this wonderful session on the soft tissue sarcoma. And welcome, ma'am. Please kindly proceed the session, ma'am.
Thanks so much, Moinuddin. Sincerely thanks, Sandeep, for inviting me from ISI. And sincerely thank my side, Rajesh, Priyanshi, Anishika, for organizing the talk today. I will be speaking on advanced soft tissue sarcoma. This is an unattended field for all of us. We need to have more research. And probably the reason we have not had enough research is the number is not very large until now. And that's probably the reason we need to have robust data, which has to extend over decades to get some substantial answers out of it. We have been talking about neomolecules based on sequencing of advanced sarcomas, but again, a long way to go because the results we have are based out of 20 patients and 30 patients. So I'll try to present an overview, and I think we'll take up all the questions in the panel discussion which will follow, which will be led by Dr. Murli Subramaniam. And then I'll also introduce the panelists. So soft tissue sarcomas are mesenchymal neoplasm with over 50 subtypes, which vary molecularly, histologically, and in clinical features. It can happen in any site of the body. Extremity, especially lower limb, is the most common site. There are other sites like trunk, head and neck, and retroperitoneum. Retroperitoneum probably having the worst prognosis. Most common subtypes include undifferentiated pleomorphic sarcoma, liposarcoma, leiomyosarcoma, synovial sarcoma, and of course, malignant peripheral nerve sheath tumor, besides others. Soft tissue sarcomas is a rare subset, as we all know, and it is less than 1% of adult carcinoma cancers. And that's probably the reason we have lesser data, lesser drugs. Metastasis is common, and almost 50% of all soft tissue sarcoma will metastasize, most common site being lung, and they often die because of it. So this is a SEER data which was long back, 20 years back, which showed that dermatofibrosarcoma has almost 100% 5-year survival. But as you look at the other subtypes, the next is possibly liposarcoma and then other fibrosarcomas, and the worst is Kaposi's sarcoma. But by and large, all other sarcomas tend to do worse, and especially high-grade variants. Looking at the Indian data, almost 1% of all cancers are soft tissue sarcoma. Most commonly occurs in the 3rd and the 5th decade, lower extremity being more common than the upper extremity. In our country, almost 3/4 of these tumors are more than 10 centimeter in size. So they are already advanced by the time they come to us. Lung is the most common site of metastasis, diagnosed as high grade often, and male sex has a slightly more number than women. This is a smaller study of about 188 Indian subsets. This is it was 6 studies pooled together. And in this, we found out that liposarcoma is the most common subtype in our country, being 25%. However, we have smaller studies which says leiomyosarcoma is predominant subtype as well. Undifferentiated sarcoma is the other important subtype. So talking about the first line treatment of soft tissue sarcoma, we'll start with doxorubicin and probably end with doxorubicin. So the most landmark trial was EORTC trial, which compared doxorubicin with ifosfamide. Picasso trial, which compared with a newer drug called PAL ifosfamide. SARC-21 was a trial which compared doxorubicin in combination with ivofosfamide. However, this is not in production at this juncture. Then there was a British trial which compared doxo with gemcide docetaxel. So talking about doxorubicin, which seems to be a hero in soft tissue sarcoma, well, this was a phase 3 trial, EORTC trial with about 326 patients of advanced soft tissue sarcoma of all subtypes, which compared doxorubicin in 1 hour arm versus doxorubicin plus ifosfamide. This ifosfamide was given either as a continuous infusion or as a bolus, and the PFS was in favor. Actually, both did not show any superiority in either arm. So doxo was as good as doxo plus ifos, whether given as continuous infusion or bolus. The overall survival was only in the tune of 12 months. So this was basically stratified as doxo bolus and doxo infusion, doxo plus ifosfamide, where ifosfamide was bolus or infusion. And yes, there was a median overall survival advantage, but none of the arms showed superiority. So at this juncture, wherever possible, doxo should be used as the first line, given as 75 milligram per meter square. It can be replaced by liposomal doxorubicin. And where synovial sarcoma has definite advantage of adding ifosfamide in the first line setting. So when there is synovial sarcoma, we definitely think of MAID regimen. But in other subtypes, you could think of either single agent ifosfamide, doxorubicin or doxorubicin plus ifosfamide. Talking about the second drug, PAL ifosfamide, that this was Picasso 3 trial in which there were 447 patients. So this was relatively larger study, which compared again doxo on one arm and in combination in the other arm. Again, none of the studies, none of the arms showed superiority of one versus the other. And so doxorubicin single agent remained the standard of care. We had actually good data with this drug called ifosfamide. However, eventually this was not in clinical development and at this juncture not available in market. The combination arm did show slight superiority in terms of response rates. However, the OS and PFS remained same. Then there was a larger British study which compared Gemcite docetaxel in the first line setting. And this was doxorubicin in one arm, which was the then standard of care. And this study was published in 2017. This was 10 years after doxorubicin became the standard of care. And it was compared with gemcitabine docetaxel. Now, when you look at it, gemcitabine was in a much lower dose. This was 675 milligram per meter square given as day 1 and day 8. Whereas docetaxel was given on day 8 as 75 milligram per meter square. The PFS and OS was exactly same with no advantage on either arm. The serious adverse events were also similar, but in spite of this study, doxorubicin remained the first line treatment for till now. Now, there was a monoclonal antibody also which came in our way, and this was olaratumab. Olaratumab is an anti-PD-L1 alpha monoclonal antibody, which is a human IgG1 monoclonal antibody and selectively binds to the alpha PDGFR receptor with a high affinity. At that point in time, when the study was published, there were already xenograft sarcoma models which had shown response to this drug. So this was a 1:1 randomization of olaratumab on one arm along with doxorubicin. This was given as week 1 and week 2 in a 3-weekly cycle, and doxorubicin in the second arm as a single agent. Initially, when the results were published, there was a lot of talk that this may become the next combination to be used with advantage of the combination arm in terms of median survival. However, the subsequent year, phase 3 was announced, and this was the announced trial schema in which again 1:1 randomization was done in the olaratumab arm plus doxorubicin versus doxorubicin alone. And there was obviously a switch possible in this. And this study did not meet the primary endpoint of OS prolongation in the overall population. And therefore, this was not continued further as an investigational study. In the second line treatment, what we need to know is the treatment is histology driven. At this juncture, we still don't think of RNA sequencing in the second line setting, but all of us should advocate wherever feasible. But in the second line setting, based on the histology, various continents have various approvals. And in sarcoma, way back in 2007, we had trabectedin approved for all types of sarcomas. Pazopanib was approved in Europe in 2012 in all sarcomas minus liposarcoma. In the United States in 2015, Gemcite docetaxel was FDA approved for all sarcomas. Leiomyosarcoma and translocation-related sarcomas, trabectedin was approved. And 2016, liposarcoma was had approved eribulin in Europe and the US. So this standard will be the schema of management in which we have histology noted. And in non-specific histology, we would think of gemcitabine-based combination. So first is non-specific histology, including undifferentiated sarcomas, which are generally high grade. And there's robust data through various phase 2 studies, which shows that undifferentiated sarcoma, leiomyosarcoma, and all other sarcomas, including uterine leiomyosarcoma, has a survival advantage, PFS and OS advantage with high overall response rate when gemcitabine docetaxel is used as a combination drug. Talking about non-liposarcomas, in which pazopanib is the standard of care by the study result of phase 3 trial known as pellet study. So pazopanib was compared in this setting with placebo, which showed a PFS advantage of around 3 months, which is 4.6 versus 1.6 months. And OS was also in favor of pazopanib arm in the tune of 12.5 months, which was compared to 10.7 months in the non-pazopanib or placebo arm. In the liposarcoma, at this juncture, eribulin remains the standard of care. And eribulin was compared with dacarbazine in advanced liposarcoma. Actually, there are studies which compare eribulin with temozolomide as well. And temozolomide is actually the oral analog of dacarbazine. So eribulin and dacarbazine was 1:1 randomization, and the primary endpoint was overall survival. The OS was met in the intent to treat arm with an advantage of around 2 months. This was also followed up. I would not call it statistically significant when we talk about PFS, but it was slightly leaning towards the eribulin arm. When we talk about liposarcoma subset, the dedifferentiated population had a remarkable benefit. Pleomorphic liposarcoma again had substantial benefit versus myxoid or round cell type of liposarcoma. When we talk about leiomyosarcoma and other subtypes, trabectedin was established as a standard of care based on ET743 study. Initial study did not show overall survival advantage. However, the response rates were substantially high. So at this juncture, when you classify all the 3 drugs and have to choose which one, pazopanib will be the right choice for non-liposarcomas, trabectedin primarily for all sarcomas, however, strongly favored in leiomyosarcoma, and eribulin would be possibly for liposarcoma, which is the highest number of sarcomas in our country. This is a rough estimate based on the histological subtype, where eribulin is favored in liposarcoma, but also has good data in leiomyosarcoma. Trabectedin is substantially favored in leiomyosarcoma, but has good data in liposarcoma as well. Only thing which we need to note is that if a patient has been given anthracyclines in the first line setting, while giving pazopanib and trabectedin, we have to consider cardiac dysfunction, and it has to be evaluated from time to time. Talking about NTREC, which all of us are definitely interested in, but we still have some time before it is easily accessible in Indian market. So talking about neurotropic tyrosine receptor kinase inhibitors in soft tissue sarcoma, well, these are important studies, and interestingly, pediatric soft tissue sarcomas have shown greater than 80% incidence of NTREC fusion gene. This fusion gene was mostly analyzed by RT-PCR or RNA-based validated NGS sequencing, and multiple subtypes of NTREC have been reported. Both larotrectinib and entrectinib is approved NTREC inhibitors by the FDA in all solid tumors, whether they are pediatric or adult, who harbor NTREC fusion at this point in time. And the overall response rate has been remarkable. I mean, we have not heard of these kind of ORR in any drug or any disease. So they have almost touched 100% response rate with these drugs. Now, lastly, eribulin we all know about, and of course, we need to focus a little bit more on this drug. So this was LEADER study, which came up last year in ASCO, which showed that the combination of lenvatinib along with eribulin in the subtypes liposarcoma and leiomyosarcoma had a survival advantage. So the schema of this was that lenvatinib, we already know that eribulin is approved in this setting. Lenvatinib is a multi-targeted anti-angiogenic inhibitor with VEGFR 1-3 receptor function. It also is an FGFR inhibitor. It is a PDGFR inhibitor besides being RET and c-KIT inhibitor. It also has known to have immunomodulatory effect. So this was a leader trial was a phase 1B, phase 2 study, initially dose escalation study with dose limiting toxicity noted, and then taken up to phase 2 with the primary endpoint being only objective response rate. So there were various levels of dose escalation, and the dose of lenvatinib used in this study was 14 milligram per day. Eribulin was used as 1.1 milligram per meter square on day 1 and day 8. All these patients were either liposarcoma or leiomyosarcoma, had received at least one line of therapy. And yes, there was a PFS advantage and, of course, an OS advantage as well. Actually, leiomyosarcoma had a slight better results than liposarcoma in this study. And the median OS reported in this study was remarkable. That is 27 months. I think we need to look for more results. And well, yes, according to one study in 2022, ORR was reported as 20%. And in the other study, which was published in Lancet 2016, it was only 4%. So leader study, the primary endpoint was met and demonstrated promising efficacy and manageable safety profile when a combination of lenvatinib along with eribulin was used in advanced liposarcoma and leiomyosarcoma. And this was not primarily related to FGFR expression or FGFR biomarkers in this tumor. We need to have novel combination and, of course, better data for the same. Talking briefly about immunotherapy, well, for 20 years, interferon and interleukin was tried in soft tissue sarcoma, and cytokines were proven to be ineffective. There's a lot of research around dendritic cell vaccine, customized vaccine to the patient, tumor-specific immunotherapy, and this remains still investigational. However, smaller studies have been promising. There's a very interesting T-cell therapy against NY-ESO-1, which is an autologous T-cell, taken almost like a CAR T cell for synovial sarcoma and liposarcoma, which again is investigational at this stage, but has shown good results. There are studies about single-agent checkpoint inhibitors and combination checkpoint inhibitors in the form of Pembro with 18% ORR. I would call it responses as against any other drug. This is primarily for undifferentiated sarcomas and liposarcoma. Nivolumab has been tried in settings with or without ipilimumab, with a median progression-free survival of 4.4 months and ORR again of 16 months. So soft tissue sarcoma is a heterogeneous group. Doxorubicin remains the gold standard at this point in time for locally advanced and metastatic setting. Newer agents include eribulin, trabectedin, and pazopanib. A lot of research is still awaiting. Thanks so much. So I will ask Dr. Murli to take over the session from here. Dr. Murli is Director, Medical Oncologist at HCG Daycare Centers in Bangalore. He has been practicing for over 15 years in Bangalore, a senior practitioner with a big, remarkable practice and influence, and a lot of sarcomas, of course. The panelists are Dr. Karthik Udupa. He's a professor and head of the department from KMC Manipal. Dr. Ravi, who's a senior consultant medical oncologist at HCG Hospitals in Bangalore. Dr. Satish Sethi, who's a senior consultant medical oncologist and heads the research wing in HCG Hospital at Bangalore. Dr. Pratyush V, he's a consultant medical oncologist at Sri Shankara Cancer Hospital in Bangalore. And Dr. Nasir, who's a consultant medical oncologist at HCG Hospital. So over to you, Murli.
Great, thank you. Can you help me share the slides, somebody?
Our discussion will start.
Yes, so you can share the slides. Here down the share screen button is there.
1 second. Is there any variation? I'm not getting the share screen button here.
1 second. So now you can check, you can see the share screen button. Just check that green button is there.
Sorry, I'm not able to get that.
Sir, can you mail your slides to me so I'll share?
I'll do that.
Yes, so I'll send you my email ID.
Is it visible now?
Yes, sir, it is
Yes,
visible.
yes.
Yeah, I just logged in once again. Yeah, that was it. All right. That was a comprehensive presentation by Dr. Niti. I think she did touch upon most of the aspects in advanced soft tissue sarcoma. I welcome all the panelists. I think all of them are there. Satish, Karthik, Ravi, Nasir, and Pratyush. Here I have been given slides which are kind of, which gives an overview of the soft tissue sarcoma right from surgery to adjuvant, neoadjuvant, and then metastatic. Let us try to take the points from Dr. Niti's presentation and then see where we can apply these and then do some. There are a lot of questions, of course. Sarcoma, as we all know, that it starts with doxorubicin and it ends with doxorubicin, as Dr. Niti pointed out. Not much development has happened especially in the systemic therapy of sarcomas. So with that understanding, I have been given these slides and this to address some of the controversies. And the first and the most, I think this is the most difficult question for medical oncologists. I start with Dr. Satish. In what percentage of retroperitoneal liposarcomas you see an R0 organ resection? In your practice, when you see a patient in a post-op setting, Dr. Satish, what would be your percentage of retroperitoneal sarcomas with an R0 organ resection? Yeah.
Hello. I'm
Yes,
audible,
Satish.
sir?
Audible, Satish, clear.
Yeah. Yeah, I can say less than 30%, sir. Most of the time, like, see, the presentation retroperitoneal sarcomas will be advanced. Majority, it depends on the good surgical and because aggressive surgeon, he tried to clear as much as possible. Like I can say that almost 30 to sometimes 40%. It's based on what is the initial bulky that the stage up to the present. My OPD patients, like I'll try to see that 40% they try to R0, remaining something it will have a margin positive, something they'll have a sometimes I think because it's adherent to the visual adjacent organ, they try to leave it. Then finally, we have to land up chemo and radiation. We have to be ready prepared mentally. They'll be usually the huge size, more than 5 to 10 centimeter will be there. This is what I see in the practice.
Absolutely. I mean, that's what most of us say. Karthik, do you have any personal experience, opinion on this? Yeah.
Yeah, I mean, probably I think R0 around 50%. So I can tell 50-50.
Okay. So, most of us, we agree that attaining an R0 resection in the retroperitoneal region is difficult. because of presence of various structures, and end up with either an R1 or an R2 resection. Many times it is even an R2 resection, which has not been put up in the slide. So, Dr. Ravi, in your practice, this is a surgical question, but I'm forced to ask this question. But at least, do you look at these things, whether an en bloc resection or a compartmental resection? Basically, even if you see that it's not involved, you try to get a clear margin. Is that important, or just you're happy with just to remove the tumor? What kind of do you look at these things in the report, en bloc versus compartmental dissections? Yeah, Dr. Ravi.
Yes, sir. I think this is the most important thing what we see in the report. First, we will see how is the margins and what is the adequacy of surgery. Then only we see, okay, what is the histopathology grade and other things, what needs to be done. Because unless we achieve a good R0, rest whatever we do, I think it will be only palliative intent.
Absolutely. I mean, it's, the resection status is very, very important. And that's why the first question of retroperitoneum being the site where getting clear margins is very, very difficult. Dr. Nazir, do you have any opinion on this? Yeah.
Yes, sir. Like optimal R0 resection is what I would expect, and like in my practice, almost 50% of cases I have an R0 resection, and rest 50% is like R1 or positive margin. And I would expect to have a complete surgical resection and optimal extension and solution.
Right, right. So that is what the data also says. Data supports that if you have an extended resection, even in the absence of a clear tumor involvement, you see that the local recurrence rates are much less. What you see in this current study, which has been displayed here, with the 5-year local recurrence rates of 29 versus 48 if you just do a standard resection. This is another study which gives a 3-year local recurrence rate, 10% for extended resection versus close to 50% for a simple complete resection. So resection becomes very, very important, and that's the first important step towards attaining cure. And extended resection actually results in a 3.3-fold increase to a rate of lower recurrence rate. Lower recurrence rate generally transforms into a better outcome for the patients. The next important decision most of us are usually stuck up with, which are the cases generally we do pulmonary metastatic, and we know that lung is one of the common sites for a distant spread for soft tissue sarcoma. Dr. Pratyush, do you have any preference of the histology or patient presentation where you actually perform a pulmonary metastatectomy? Is there any particular imaging characteristic? Yeah.
So I would definitely involve my surgeon, sir, basically, first thing. And it's not about more of the number of metastases. Basically, for me, when the patient is going to have a pulmonary metastatectomy, it's basically the disease should be in control. It should not have any extra pulmonary. Everything extrapulmonary should be in control, and especially maybe leiomyosarcoma patients may benefit from a pulmonary metastatectomy. If the primary, apart from the lung, everything is in control, those kind of patients, definitely if the surgeon feels that they are able to get a definitive margin, they are able to resect all the metastases, those patients may benefit, in my opinion. But definitely the surgeon should clearly be involved and everything should be seen, then only maybe. And fitness of the patient also becomes important.
Absolutely. I mean, most of the points are absolutely correct. The extrapulmonary disease should be under control, especially the local disease has to be controlled. The studies do back up with this pulmonary metastatectomy with therapeutic intent for soft tissue sarcoma. We commonly see in pediatric sarcomas, it's a common procedure for an extraosseous osteo or an extraosseous Ewing's. When you have this is a very common procedure which is done, especially when lung is there. But in adult soft tissue sarcoma, it's a slightly different ballgame, and not all the patients are subjected for pulmonary metastatectomy. So if you look at that, when a pulmonary metastatectomy is done, median overall survival after the first pulmonary metastatectomy, it's actually 33 months, and the DFS is 6.8 months. So rightly pointed out, Dr. Pratyush, LMS, leiomyosarcoma histology type, where the primary tumor is less than 10 centimeters. And if there is an increasing gap from the primary tumor resection, that is the metachronous metastasis, when you have with a longer duration of disease-free interval, and if there are fewer lung metastases, I think these are all the right recipe for pulmonary metastatectomy. So there are also studies which indicate that a minimally invasive resection actually gives a better outcome rather than an extensive surgery. The median OS comparing 44 versus 29 months. So 5-year overall survival is kind of a gold standard for pulmonary metastasis. Pulmonary metastasis is done, and it's not a this thing that 5-year OS is a cure, but majority of the patients pull on till 5 years because of the pulmonary metastatectomy. So carefully selected patients, actually pulmonary metastatectomy can give long-term good outcomes. So slowly we'll move on to the neoadjuvant of the adjuvant. We're moving into the medical management from surgical. Dr. Satish, any thoughts on neoadjuvant chemotherapy in soft tissue sarcoma? What are your thoughts? Is there any role for neoadjuvant therapy? Is there any specific indication where you can use neoadjuvant chemotherapy? Satish, yeah.
Sir, it is a multidisciplinary approach. We'll discuss with the surgeon, especially pediatric sarcomas, especially RMS and Ewing sarcoma. These kind of things that we'll try to have the neoadjuvant, especially the RMS near the eye or otherwise in the pelvic. You want to organ salvage, all those things. We'll try to have a neoadjuvant approach. In adult, we'll try to have a very few, especially sarcoma is a very classical example. Limb salvage, we try to have a neoadjuvant and even sarcoma. But coming to this non like a skeletal, like soft tissue sarcoma, definitely we'll try to have a few things. Synovial sarcoma will try to have that. There is a chemosensitive tumor, but most of the time we'll try to have a limb salvage surgery. We want to do with the extremity sarcomas. There we want to after discussing with the surgeon, the plane of resection is become want to easy. That chemosensitive sarcomas will try to go. Otherwise, sometimes even though a sarcoma is a surgery is the first preference choice, we'll try to see some of the otherwise I don't think not all sarcoma will try to go for a neoadjuvant chemotherapy.
True. Dr. Karthik, any other thoughts?
Yeah, I completely go with Dr. Satish's opinion. So pediatric, yes, there are many sarcomas, we go with the NACT. But in adults, even though the data is not very strong towards neoadjuvant chemotherapy, yes, of course, it requires a multidisciplinary tumor board discussion. And if the surgeon feels that shrinking of the tumor makes a difference, say there are the vital structures can be preserved if we give NACT and if there is a marginal decrease in the tumor size. So in chemosensitive tumors, yes, probably I would be inclined towards giving NACT, like say extremities, synovial sarcoma is one of the examples. So maybe in a selected group of sarcomas, I would like to give NACT.
Okay. Dr. Ravi, when you're giving neoadjuvant chemotherapy in adult soft tissue sarcoma, assume it's an extremity sarcoma, are you looking at overall survival here or the local benefits in terms of reduction, bulk of the disease, making surgery that much more comfortable?
Yeah, it will be only for that local benefits, sir. First, making surgery surgically possible and make sure that the margins are negative. This is the main aim what we are looking in neoadjuvant.
So why neoadjuvant? I think which has been rightly put that to downsize the tumor and improve the resectability and the quality of margin. Some of the centers do include radiotherapy. As we all know, a couple of panelists did indicate that multidisciplinary approach is the best way forward. So you have to involve the orthopedic surgeon, musculoskeletal surgeon, and the radiation oncologist to get the best result. Local RT can be incorporated in the neoadjuvant protocol. This is especially for large, high-grade extremity tumors like the synovial sarcomas. Unfortunately, all of these approaches have failed to show survival benefit. So this is one of the examples. The picture showing myxofibrosarcoma with good response to neoadjuvant. Dr. Satish was talking about Ewing sarcoma. As we all know, neoadjuvant therapy is a standard protocol, even whether it's osseous or extraosseous sarcoma. So neoadjuvant chemotherapy is not a standard protocol. It has to be discussed with the multidisciplinary. Dr. Nazir, do you normally incorporate radiotherapy in your protocol for neoadjuvant therapy in sarcomas?
In general, no, I don't incorporate radiation therapy as a neoadjuvant protocol. But definitely as a my MDT complete panel discussion, if there is any benefit locally with radiation therapy, we can consider it as a team decision. Individually, I would not recommend radiation therapy as a neoadjuvant approach.
Dr. Pratyush?
No, sir, we would not prefer radiation as a neoadjuvant therapy. Again, it all depends on the histology and the type of tumor. If it's a chemosensitive disease, I would say chemotherapy is the best option than radiation if you are trying to get those margins. Because once radiation is done, the surgery becomes very difficult once the radiation is done. And the adjuvant chemotherapy, if any indication is that also becomes very difficult for the patient.
Dr. Satish, any thoughts on radiotherapy in neoadjuvant? Dr. Satish? Okay. So there are some centers who do practice radiotherapy along with neoadjuvant chemotherapy. The sequencing of radiotherapy is a question whether to give concurrent with chemo or.
Murli, can I just say one thing?
Please.
Actually, for extremity sarcoma, post-op versus pre-op RT is widely discussed. And they say that both have advantages and disadvantages. And the advantage of pre-op radiation, although everybody says vascularity is compromised for the surgery and all, but that is also an advantage for radiation because we have well-defined anatomy. The vascularity is preserved, and so we don't have hypoxic cells. The effect is better. And so downsizing works very well in pre-op setting.
Absolutely, I completely agree. And there are some centers who follow brachy also. Brachytherapy in soft tissue sarcomas. So it is not entirely a kind of an approach which should be neglected. Definitely to be kept in mind. The sequencing is the point in question. Dr. Nidhi, feel free to put in your views whenever you want to. Please, thank you. Yeah. So in neoadjuvant, let us come to systemic chemotherapy. Whenever you're using neoadjuvant therapy, does histology play a role, or does histodriven treatment actually help? Dr. Karthik, you can take this question. Yeah.
And most of the patients, actually, histology doesn't, unless it is, as we are told, some sarcoma. I mean, some of the cancers like RMS, Ewing's, leave apart those things. But the sarcomas, what we are discussing here, histology doesn't matter. So if it is the first line, it is adriamycin-based chemotherapy what is to be given.
Okay. Dr. Ravi, any opinion on the histology-driven treatment in neoadjuvant?
Yes, sir. In uterine leiomyosarcoma, we use gemdosi. Otherwise, it's ifosfadria across.
Ifosfadria across. Okay, interesting. Okay. Yes, it is an approach which has questionable significance, histology-based treatment. there is a large randomized study which has compared IFOS epirubicin versus using a histology-based approach. Like you can use, as Dr. Niti presented extensively on trabectedin myxoid liposarcoma, or using ifosfamide in synovial sarcoma, or an ifos etoposide in peripheral nerve sheath tumor, as gem dosi, as Dr. Ravi pointed just now in UPS. So these are some of the histology-based approaches which was done. But largely from the trial, it was concluded that they have similar DFS, but it has inferior overall survival. The regimen which stood the time is actually trabectedin for myxoid liposarcoma was actually not inferior to ifosfamide with epirubicin. So that's an interesting message. I mean, there is a lot about this molecule trabectedin in liposarcoma. We should careful whenever we have the situation, we should use this molecule. There's another study which I will present later in the slide. It cannot be written off, but yes, there is no harm in practicing a broad-based approach with an ifosfamide, with an anthracycline like doxorubicin. Now moving on to the adjuvant therapy, Dr. Nazir, is adjuvant chemo standard for all soft tissue sarcomas? Do you have any approach for that? Which patients are eligible for an adjuvant approach in soft tissue sarcoma? Dr. Nazir?
Yeah, depending on the resectability status, and if it is a margin positive, consider, and burden of the disease also. Extremity sarcomas more than 5 centimeters, 5 to 10 centimeters, I would consider systemic chemotherapy.
Okay. Dr. Pratyush? Yeah.
I would agree to that, sir. Size 5 centimeters greater than that. And I would add deep-seated tumors, sometimes they may require adjuvant chemotherapy, and high-grade histologies, yeah, definitely. Extremities.
High-grade extremity and deep-seated tumors. Absolutely. It's not for all tumors, right?
Yes, it's not for all tumors, sir. Definitely.
It's not for all tumors. So this is a long debate. Published data, individual trials, large phase 3 trials, and meta-analysis. The popular amongst them are 2 or 3 meta-analysis, the soft tissue sarcoma meta-analysis. The earliest one was called the SMAC meta-analysis. It did show that an anthracycline-based therapy improved the recurrence-free interval. There was a tendency to improve the overall survival, but it was not seen across all subgroups, as rightly pointed out by the participant, that the subset with extremity and trunk had the maximum benefit, 7% overall survival over a period of 10 years follow-up. Similar follow-up in the 2008 meta-analysis is actually a positive study which showed an OS benefit. I think this is the only study as of now which shows overall survival benefit in the adjuvant setting. Also, it did establish the importance of ifosfamide as a molecule in soft tissue sarcoma. Pooled DRTC results, again, it was a negative study for overall survival. So it's a mix. Meta-analysis also was a mix of few positive and few which were negative. But by and large, most of us agree that extremity sarcomas like synovial, if you have a deep-seated tumor, high-grade, and residual disease more than the tumor size more than 5, they are all best suited for adjuvant chemotherapy. So, Dr. Satish, are you there? Optimal regimen, what do you use in your practice? When adjuvant chemo is decided, what do you use?
I try to see that 4 to 6 cycle. It depends on sometimes histopathology, like a evening sarcoma comes, like we have to have a prolonged almost 1 year. But here, like most of the soft tissue sarcoma, like up to 6 cycle, we try to use it. Sometimes tolerance is the issue. We might stop at even 4th cycle.
Dr. Karthik, do you use MAID or AIM kind of regimen? What is your standard of adjuvant in a patient who is eligible for combination?
I don't use MAID usually. I usually use adriamycin based ifosfamide adriamycin 4 to 6 cycles, as Dr. Satish discussed.
Okay. So the number of cycles. Anybody who uses 3 cycles? Dr. Ravi, any comments on 3 cycles? 3, 5, or 6?
Generally, we stick to around 4 cycles, sir. 3 I have not used unless the patient tolerance is very poor.
Right. There are data for 3 cycles being as effective, but generally most authors do say that around 5 or 6 cycles of adjuvant chemo. By and large, what is accepted is around 5 or 6 cycles. Tolerance is a big issue, as we all know. Using 5 or 6 cycles of ifosfamide is a huge challenge. Yeah. Now, moving on to the metastatic tumor, metastatic soft tissue sarcoma. That is where all the presentation by Dr. Niti was on the metastatic soft tissue sarcoma. Let's see if you can use those.
Hello, Sir Satish.
Hello. Satish, yes.
Sir, most of the time, I think now everybody like ifosfamide adriamycin except some uterine leukemia sarcoma. Maybe some few subset we might change. Only thing is that delivering optimal IA regimen with ifosfamide, like practicing a full optimal dose, that is more important because if you don't deliver compromised dose, like that's a one major issue in our practice. Like I say, elderly, that comorbidity we might compromise. Young fit person should have to make sure that they're getting the full optimal delivery of the ifosfamide. That is more important, sir.
So what is your practice? What is the dose of ifosfamide you use in practice?
See what will happen, like many times they'll try to have like a capping up dose, all those things that should not do it. And dream doxorubicin also, like because that combination, like what like you have a 60 mg per meter square of doxorubicin and ifosfamide, you can go like, they try to like because many times like you'll have 2.5 gram 3 gram, because that young and fit person like they're going, like we'll try to go with a whether it's a 5-day regimen or like a 3-day regimen, that we have to see that at least we are, because many times like compromising the dose is happen many times happening. So because we try to young and fit person will get the full dose. So that's what we try
That's
to
a
do. Yeah.
very important point. Optimal dosing is very important. Yeah. So metastatic soft tissue sarcoma. So the initial approach when it comes to biopsy. So we have discussed how histology is important. In some cases, we can look at histology and try to get the maximum benefit out of certain molecules. How would one approach histology which says NOS or an undifferentiated sarcoma? Dr. Karthik, how do you take this report? Do you order for additional investigation, or you take that report which says vimentin positive, undifferentiated, or an NOS sarcoma? Yeah.
Always, I think it is better to get a clear-cut histological diagnosis. So, if somebody is able to give a clear histology, it's very good. If it is something like undifferentiated after, after the extensive IHC approach also, then I think we have to take it like undifferentiated sarcoma and probably go with the report. So try to get the clear-cut histology as much as possible, and definitely in those patients, sending a NGS will be very useful.
Dr. Ravi, would you do anything to get more out of the NOS histology? Any other test which can? Of course, it's not commonly used in practice. Is there anything which can do more to get more out of the NOS, which can give us the specific diagnosis?
Yes, sir. I think histology is very important, especially if the pathologist is not convinced about the adequacy of tissue. We advise rebiopsy, and sometimes we take second opinion, especially in practice with eye centers like Dr. Borges and all. I think we should aim for specific histology, because at least not in the first line, in later lines it will help in the management. And the NGS are helpful in rare sarcomas, or probably a low-grade sarcomas where chemotherapy may not work to the extent what we think.
Dr. Murali,
Dr.
if I
Nazir.
can add something, it's like translocation, even though we
Exactly.
talk about translocations, maybe I think now there are so many labs where they're doing, I mean, there is a specific sarcoma translocation panel, which probably we can send and try to get a diagnosis. So that is one
Absolutely.
thing.
That's the point I was looking at. Specific translocations, although it's rare in practice, you can look at doing specific translocations like an X18.
So again, can I
yeah.
say something?
Yeah, please.
So actually, like everybody said, translocation related sarcomas possibly will also have different drug. So if we are in doubt, it may be useful to do an NGS there. And especially conditions like ESS, endometrial stromal sarcoma, or uterine leiomyosarcoma, they also have, I mean, treatment may change if BCOR is positive, cyclin D1 is positive. So there's definitely a diagnostic dilemma when it is uterine range of sarcomas. But in other sarcoma, identifying a translocation related sarcoma may again have treatment related, there might be a different drug we may want to use upfront. So yes, in gray zones, we should order NGS.
Absolutely. So, Dr. Nazir, NGS upfront, do you use in soft tissue sarcomas? Dr. Nazir?
Yes, sir. Like other panelists have commented, if we have any rare sarcomas where we think that conventional treatment might not work, especially in these scenarios, I would definitely advise to get an upfront NGS done because
The voice is loud. Dr. Pratyush?
Yes,
NGS
sir.
upfront?
Yes. Even in patient who knows the histology, especially in low-grade sarcomas, I would definitely prefer an NGS testing. If you don't know the histology, again, I would ask the patient, I would counsel the patient for an NGS testing.
So, other than picking up the rare mutation, Dr. Pratyush, what are you specifically looking at in an NGS?
So again, you are looking at mainly the targeted therapies. Again, second, if it is a low-grade sarcomas, again, if there is any MMR deficiency or intrec mutations or any other rare mutations that are present, which are mainly targetable. I am talking about the targetable ones. Mainly the non-targetable ones may not be useful. The 90% ones may not be useful, but the rare 10% which are targetable, that may be helpful.
Absolutely. Dr. Satish, NGS, what would you specifically look at? Anything else on NTRAC has been told? Anything else you look at in soft tissue sarcoma specifically?
Sir,
You always
NTRAC
pick up
is
some
one.
rare mutation.
Yes. That the common thing is c-KIT mutation also will find out. That's the one thing. Many times we found out on IHC also many patients pleomorphic sarcoma of mediastinum treated almost 3-4 lines. Then finally one IHC we found that c-KIT is weakly positive. We put the patient on almost nearing 2.5-3 years with a c-KIT and pasopiniblator. Like this, like where they try to help actually. That c-KIT is one thing, and other thing is about already NTRAC is there. There are few like rare sarcomas like that I told MSI. It is more of like it is a cold tumor. We don't get very rarely. There are certain tumors will try to have the now CDK inhibitor also they try to have that. There is a pathway that abnormality will see that. That is alveolar soft tissue sarcoma, and even immunotherapy also role is there. Some certain sarcomas we try to have that alveolar soft tissue sarcoma also immunotherapy role is there, and very few things. Very rarely we'll try to have we try to have a rare mutations which you might find out. Then we try to utilize a clinical practice. Very rarely will come across. Not very
Absolutely.
like how it is evolved in lung cancer and other cancer. It is very few.
Very rightly pointed out. It's not a favorite tumor wherein we order NGS that frequently. It's very rarely we pick up these actionable mutations, as rightly pointed out. Maybe in less than 1% cases we might pick up an actionable mutation. NTRAC is one which is commonly looked at, and Dr. Niti pointed out that it's more often seen in the pediatric sarcomas. It's not uncommon. Sometimes of the rare mutations, even you can pick up a BRCA sometimes, and that could be useful. So NGS, not always, but in specific occasions, you can think about this. So we have discussed this first line single agent versus combination. Dr. Niti has presented single agent as single agent anthracycline as good as combination. There are situations wherein the performance status do permit combination chemotherapy can be used, and it has shown modest benefit when it compares to the single agent chemotherapy in the palliative setting. So if you look at the sensitivity part between ifosfamide and doxorubicin, this chart and the bar chart clearly shows how the sensitivity part between various sarcomas like leiomyoma, synovial. Synovial ifosfamide is a big hero for synovial sarcomas. And you see that doxorubicin is a much better agent for liposarcoma as well as in leiomyosarcoma. This is a comparison between ifosfamide and doxorubicin and looking at the sensitivity pattern. There's one interesting combination, doxorubicin and bactridine. Dr. Karthik, have you had an opportunity to use this combination upfront in LMS? Any thoughts on this, Dr. Karthik?
This is actually, I feel that it's a very scary combination because doxorubicin and rabactidine. I know we have seen rabactidine itself is a very toxic regimen. I mean, majority of the patients do land up in a lot of neutropenia. I know there is a study combining these two has shown BFS in LMS. That is, I think LMS 04 study or something like that. So, but definitely, I think our patient, I don't know how much they will be able to tolerate this combination. So I have not used this combination.
Even I have not used. I'm trying to get inputs. Dr. Ravi, have you used?
No, sir, not in combination. And
not in combination. This is upfront. I think this study is upfront. I'll present that.
yes, sir.
Anybody else in the Dr. Niti, have you used this in combination?
Actually, we have discussed in good performance status couple of patients, but we never started. No.
Absolutely. I think the scare. I mean, we are scared about the toxicity. Well, it's a frontline setting. We most of the time we use tabactidine in later lines, and that's when we see most of the toxicity. This is a frontline study, I think.
So I think in this study they used trabectedin as maintenance, and that was possibly the reason why it did very well.
Yes. So this is the there is a maintenance arm in the tabactidine. See, and the dose is reduced. I think 1 milligram per meter square in tabactidine, and doxo is also reduced at 60 per meter square when you compare to the standard protocol. Look at this thing, the PFS benefit, median PFS, and then the median PFS benefit seen in all the subgroups, and then the median OS benefit seen in this study. This is a follow-up of 37 months. So this is one of the few studies which is positive in terms of both PFS and OFS, PFS and OS. I think we all have limited experience with this. We should sometime in a young fit patient should be looking at this combination for that specific histology. So most of the responses in the combination arm were CR and PR. Stable disease was almost equal, in fact, better in the doxo arm. Whenever there was a response, I think it was better in the combination arm. As you can see, it's 5% CR and then 32% PR in the combination arm. So, as a conclusion of the study, it showed improvement both in uterine and soft tissue populations. Major clinical benefit of ORR and OS was also observed. As per the study, the safety profile was consistent with the previous study and with manageable toxicity. Could be a new standard of care that should be looked at in young fit patients. Definitely an interesting combination. We'll quickly go through the option of choosing the second line option. Especially we are looking at now liposarcoma. How do you, I think Dr. Nidhi presented this data on all these drugs, eribulin, trabectedin, and pazapinib. Dr. Ravi, how do you choose this combination? Which one suits in liposarcoma? Eribulin, trabectedin, is it patient choice or you have a preference based on what points? Yeah.
Yeah, one is the ease of administration. I think that will be first what I will discuss with the patient. And many of the time, eribulin is the preferred drug. Only some patients who are very reluctant and who don't want IV, I will put on pazapinib. Trabectedin also is a very good drug, but we have to monitor closely. And if the performance status is good and we have exhausted with the standard lines, I will use trabectedin also. So choice-wise, eribulin, pazapinib, and then trabectedin.
Oh, okay, good. Dr. Nazir, your thoughts?
So sir, my preference would be eribulin because I have more experience with eribulin rather than trabectedin. And also, like Dr. Ravi said, ease of administration, and you don't have to have a PACC also. Like how we have to have for the trabectedin and continuous monitoring. And if there are no cardiac issues, also eribulin is favorable. So I would first consider eribulin here. And the second would be actually for a metastatic disease as a second line drug, I would consider trabectedin. And third line would be oral tablet like pazapinib.
Okay, first. Dr. Pratyush, if trabectedin is chosen, what is your common? I have a practical question here. I normally use an infusion pump. How do you use trabectedin? I mean, you keep the patient overnight, 24 hours, and then you send the patient next day, or you use an infusion pump.
I don't have much experience with trabectedin, sir. I have not used much. But
Dr. Satish, do you use an infusion pump or it's like continuous infusion 24 hours in the hospital?
So like we used to do both the protocol, but in the ovary and this as a trabectedin use, and then because nothing was there, then sarcoma 24 hours infusion. We used a few cases infusion 24 hours infusion use, but very problematic is you should be very careful about the toxicity post. We had even rhabdomyolysis also, like we had renal failure and lost patient also. It's not easy drug. Very bitter expensive.
Okay. Question I asked is, I'm a daycare man. I generally push it through the infusion pump. There is an issue of the volume. Trabectedin volume, dilution volume has to be a little bit more, and the infusion pump volumes what we have in the market is less 250 to 300 ml. Nonetheless, I just push it through the infusion pump and finish it in daycare. Yes, the side effects are very, very important. We have to keep that
sir,
in
my
mind.
question is, if you are using trabectedin, actually generally the 5FU pumps comes as that generally we keep as a 220 to 40 ml volume, and generally they go over 48 hours. So if you are using trabectedin over 24 hours, how do you do it, sir?
No, we
It's
are
the same. You can
1000
continue. We can
1000
control
ml
the
we used to
rate.
do dilution, control the rate, that through the not like syringe pump or not infusion pump.
Okay.
What we used to do in ICU, that regulating the volume drip like that. We are not used drip this or what 5FU pump or not syringe pump or dopamine. How we use that? That in a high volume dilution we have done, but problem is the toxicity. That's what we have faced.
Okay.
Yeah.
So to answer your question, Pratyush, see,
Yes,
the dosiflow meter has, you can adjust the rate. You can set it
it's
up for
there's a
24
3
hours.
ml, the 5 ml. Few pumps come with a
You
7
can,
ml one. Yes.
yes, you need to choose the right one which can push it. Like FLOT, how do you set it for 24 hours?
Yeah.
Fox is 48 hours and FLOT is 24 hours.
Yes.
So like that you adjust. But here the question comes is, for 5FU the volumes are perfectly set. For trabectedin you need higher volume.
Correct.
But still we push it through the infusion. We have not had issues using trabectedin through infusion pumps. Okay, so that's that apart. So everybody ease of administration. Most of the patients get worried. Is the treatment already over? The treatment is over in 5-10 minutes, and then so ease of administration is fantastic with eribulin, and most patients are happy with eribulin. So I think the order is correct: eribulin and then trabectedin, pazopanib. Pazopanib, we need to be careful in choosing the right patient. Cardiac toxicity and hepatotoxicity are important. One should be careful about. These are the trials which Dr. Niti illustrated. Palette. This is the only drug eribulin has met the overall survival endpoint. Strangely, it has not met the PFS. PFS met. It has met the overall survival. We'll try and see in the last slide what makes that. What makes that finding where it has met an OS point and PFS is not met. Also, there are some studies to indicate that there is. I learned by this. When I was looking through these slides, if you are using a gas therapy, that is gastric acid suppressive agent, that actually reduces the efficacy of pazopanib. So the gastric acid suppressive agents are so commonly used, and this is an important interaction with pazopanib, which brings down the efficacy. We have to keep this in mind when prescribing pazopanib, and probably that would be one of the point to choose other agent over pazopanib. We have discussed these. Let's try and see if we can brush through the specific indications for using these molecules. Dr. Satish, gem docetaxel, is it your favorite regimen to use first line anytime, or when do you use this? Where do you place this combination, gem docetaxel?
That is only in uterine leiomyosarcoma first line. Most other thing is a second line for most other failure to bypass adrenaline management. Second line.
Excellent.
Yeah.
Okay. So, Dr. Karthik, pazopanib, specific indications.
Pazopanib, I think for most of the non-liposarcomas in the second line, it is only after the adriamycin failure. So I have used it. I think it's the ease of administration. So maybe the patient is little frail, not willing for IV chemotherapies. Those are the patients you can convince for pazopanib. It's difficult to give 400 BD. So most of the patients we start with 200 BD and probably go up to 600 maximum.
Yeah, I need to be careful. This is a difficult drug to handle. Yes, absolutely. Dr. Ravi, less spoken drug, paclitaxel. Any specific indication? In sarcomas, any specific indications
Yes,
you look at?
in angiosarcomas, we use this paclitaxel.
Absolutely, it's a very effective drug for angiosarcoma.
And Kaposi's.
So, Kaposi's, yes, Kaposi's and angiosarcoma. So even in angio, it's the cutaneous and the head and neck variant. I think that's where it works better. Other sites like deep-seated lesions, I think it works that much less. So cutaneous and head and neck angiosarcomas. Trabectedin, we have discussed. Dr. Nazir, any specific indications where you place trabectedin?
Higher up, trabectedin will be considered in liposarcoma.
Okay. Dr. Pratyush, trabectedin?
Trabectedin, I would prefer a second line leiomyosarcoma. Though I have not much experience, leiomyosarcoma, I would definitely prefer trabectedin.
Okay. And Dr. Satish, ifosfetida, non-anthracycline based regimen, either you prefer this combination, either for first line or anywhere?
First line I might use in a peripheral, that's a peanuts. Okay. Peripheral malignant or not sheath tumor. Otherwise, I might use a second line failure to is not fit for sometimes like rarely we might use it cardiac non-fit patients as a second line or something. Not no other therapy is existing. Most likely in the peanuts we'll use it. Otherwise, even sarcoma and astrogen sarcoma also will use it.
Absolutely. I think In adult soft tissue sarcomas, it is MPNST, that is peripheral nerve sheath tumors. There is some role of using this combination ifosfamide and etoposide. So, what is the optimal endpoint that what we are looking in sarcoma? Dr. Karthik, you can take this. OS, progression-free, response rate, and does your choice of endpoint changes with the line of treatment? At the end of first or second line treatment, does it change?
I think we all will be happy if we get an overall survival benefit. So that is what we are, especially when we are going with in the second and third line. If if an agent is showing an overall survival benefit, definitely I think we would love to use that. So for me, I think overall survival matters the most.
Okay, Dr. Ravi, in a metastatic disease.
1 minute, sir. Yeah, I think as you rightly told, it depends on the indication and line what we are using. Suppose if it is for downsizing, objective response rates become more important, and in a metastatic setting, PFS will become more important, quality of life. Overall survival, somehow in sarcomas, it's very difficult to demonstrate with an individual drug. So it is a best say outcome, but mainly in setting in neoadjuvant objective response rate and in metastatic PFS is what I'm looking.
You hit the nail on the head. So difficult to get OS in soft tissue sarcomas. You've seen empty number of trials which Dr. Niti presented. OS is very difficult to get. By and large, even in the recent published trials, you're seeing the one on the left is the atezo-based trial, and the one on the right is the announced trial, which Dr. Niti pointed out, which is olaratumab. Very difficult to get overall survival in soft tissue sarcoma. So, nonetheless, we always aspire for it, but in a metastatic disease, response rate and PFS probably would be the initial goal. Down the line, if you're getting an overall survival benefit, that is good. So, Halaven as a drug, that is eribulin, has shown OS benefit in 2 diseases, MBC following 2 prior therapies and advanced liposarcoma. It's a staggering difference in the OS, median OS. If you look at liposarcoma, Halaven in liposarcoma, which is 8.4 in the control arm, that is dacarbazine, versus 15.6. In breast, it is 10.6 versus 13.2. So one of the rare achievements, you can say that it has an OS benefit, this drug, so that it becomes an important armamentarium in the soft tissue sarcoma. So why this actually happens, I'll just close with 2 slides. This is also a popular slide which runs in metastatic breast cancer also. Vascular remodeling and increase in tumor MVD. So it has a lot of clinical implication, rendering the drug delivery that much more to the sarcoma cells. And the mesenchymal to epithelial phenotypic switch, which is an action mediated by TGF-beta inhibition, also renders the residual tumor less aggressive. So the switch is also probably very important and facilitates a favorable immune microenvironment. So these are some of the special characteristics of Halaven, that is eribulin, which makes it a very effective drug. And this is a drug which is kind of designed. It's an adaptive therapy which is designed to use for treatment holidays, dose reductions, intermittent dosing. These are all possible with this drug, and that's one of the possible explanation of eribulin having OS benefit, but without the PFS benefit in the sarcoma studies. With that, I will conclude this. The floor can opine if they have anything specific to say. Dr. Niti, over to you.
Excellent panel discussion, Murli. I mean, I think you have covered most of the points which I did not say at all. So lovely presentation. I think we should have more discussions, especially on topics like these, which we don't do too many meetings. So thanks, Aisha, for organizing the meeting today. And again, thank Mice Ideas for a wonderful coordination amongst all of us. Thanks so much for all the participants and the panelists for joining in. Good night.
Good night. Thank you all. Thanks all the panelists.
Good night, madam. Thank you.
Thank you. Thank you, madam, for having your session and time
Good night.
and leading this session in a wonderful way. Thank you, doctors. And thank you all the panelists and the moderators.